Sure. It is so undertreated and so misunderstood that people get really frustrated because they're not believed that they have problems, or they don't have a say in how they want to be treated. Is this a good spot for it, or?
Yeah. Oh, yeah. It's very sensitive. So.
Okay. All right. That's good?
Yep.
Test. Okay. All right. Now I'm all rigged up. All right. This could get interesting. I might have a wardrobe malfunction. Hopefully not. Okay. So we're going to talk about the thyroid. We're going to talk about a lot of stuff, but the presentation itself is only probably about 45 minutes if I just talk straight. So please ask questions. Please interrupt me. Please insert your own opinions. We can get Dan involved if there's a pharmaceutical or a supplement question that I can't answer. But this is meant to be interactive. So hopefully I'm not just going to stand up here and talk at you guys, because I'd rather have you all participate with me. So what are we going to learn today? We're going to learn about the normal function of the thyroid gland. We're going to get everybody on the same page. Everyone's going to be in the same spot. Can you see all okay over there?
Yeah, but I was thinking no one's behind her. So
Yeah, I just don't want to block you if I start to walk around.
Yeah.
I'll try to change sides too, just keep it interesting. But so we'll get everybody on the same page with where the thyroid is, how it works, what it does. We're going to look at symptoms of underactive and overactive thyroid. Some of you might relate to those. We're going to talk about how we in functional medicine, that's the italicized we, assess thyroid hormones. Traditional versus functional medicine, very, very different approaches. And when I say traditional, I mean sort of the basic physician who doesn't practice functional integrative holistic medicine. Explore options for treatment. And I think this is a big one, because I think a lot of people don't realize that they have options. They just know they don't feel good with what they're doing right now. So we'll talk about medications. We'll talk about autoimmune support. We'll talk about nutritional supplements and support. And then we're going to talk about, just touching on a few other things, the impact of stress. And I love this topic of hormones and how they interact with one another. I did a talk, I guess it was probably fall of 19 here, about how the hormones dance together. And I really love the idea of how understanding all of the hormones together really creates a really well-rounded picture of an individual's hormone health. So we'll talk a little bit about that. And then I personally love genomics. It's one of my passions. So we're going to not talk in a great deal of detail about genomics, but there's a lot of stuff that's out there that we are just beginning to understand about how the thyroid, especially in an autoimmune situation, is genetically determined. So we see these families, these clusters of people who have thyroid disease, and also how we can augment and optimize treatment of thyroid based on people's genetic profiles. So that's kind of a cool new area. So you'll be like right on the cutting edge of everything. All right, so we're going to start out by meeting a pretend patient, Elizabeth. And she's 52 years old. She's been a healthy person her whole life. She has symptoms that she comes to her physician with, like fatigue. She's thinning hair every time she takes a shower. She kind of feels like she's getting gobs and gobs of hair in her hands. She's got really dry skin, decreased strength and muscle tone when she works out. She's just not getting that same workout that she was getting before. She's gained some weight, which doesn't really make sense to her because she's been eating the same and exercising the same. She has a family history of hypothyroidism. Her mom, her sister both have it. And then she started to have some irregular menstrual cycles for 9 months or so, and no periods for the last 3 months. And so there is, obviously, if she's 52, there is some crossover into sort of a perimenopause, menopause picture here, but there obviously is a role of thyroid in the menstrual cycle. And so we have to think about the thyroid. She went to her family physician and they did a TSH, and her TSH was 5.20. The normal range is 0.3 to 5.5. And she was told that it wasn't her thyroid. And she was basically offered other options for treatment. You might have depression. Let's put you on antidepressant. These are the kind of things I hear from my patients all the time. So if you're in the normal range with a TSH, you must be fine. So could it be her thyroid? I'm kind of leading the witnesses here a little bit. Like, you're like, yes, of course, that's the talk. So the thyroid gland. So let's get on the same page. Some of you probably know all this already. You're coming to this talk fully loaded, but just so we all are on the same page, the thyroid gland is this butterfly-shaped gland. It's situated between the larynx, which is the voice box, and the trachea below. And a great majority of it actually sits below the collarbone. We don't have a collarbone in this picture, but a lot of the thyroid sits under the collarbone. So in order to really see it or feel it, a lot of times you have to have somebody swallow so that it moves up above the collarbone, and then we can feel it with our hands, and then it slides back down. If it's very enlarged, it's obvious. If it has a lot of nodules, it's obvious. But sometimes it can hide. So it's not always easy to just look at somebody or feel their thyroid and understand what's happening with their thyroid health. The other thing is, because of where it's positioned in the neck, you could potentially have compressive symptoms with thyroid disease, such as difficulty breathing. Some people actually develop a stridor when they have a lot of thyroid tissue there, or they might have a difficult time swallowing. So compressive symptoms are not uncommon when the thyroid gets enlarged or if there's nodules, especially if they're on the backside of the thyroid, right up against the windpipe. So, yeah.
Sometimes hoarseness.
Yeah.
Just goes along with it. How does that tie into?
Same thing. So thyroid tissue, because it's so close to the voice box, there's all these little ligaments between the voice box and all the cartilages there that control the way that the voice is modulated. So if you have enough thyroid tissue there, if it's at the right spot, your voice can be impacted as well. Yep. Good question. So how does the thyroid work? Oh, I thought I had it all corrected, but there you go. One of my little formatting issues, but okay, anyway. So let's start at the top in the brain with the master glands. When we talk about the master gland, what we're really talking about is the hypothalamus, this gland right here in the brain. If you took the brain and sliced it in half, you could get at it. It's right behind the eye. So it's a really important place for it. And then it has this little buddy hanging down the pituitary gland, which also is considered sort of a master gland. And then there is a connection between those glands and literally every other hormone system in the body. So not just the thyroid, but the adrenals and the ovaries and the testes and every hormone producing part of you has a connection to those glands. It's a really important place. It's kind of like the Marquette interchange of brain structures. So if you have a problem in one area, you can have a problem in a lot of other areas. So what ends up happening is the pituitary hormone is released, and that's the TSH. That's the thyroid stimulating hormone. That makes sense, right? And the thyroid gland, in response to that thyroid stimulating hormone, makes its own hormones, T3 and T4. We're going to get into a lot more detail here, but they make T3 and T4. That feeds back up, and then there's this constant conversation that's happening between the thyroid gland and the hypothalamus and pituitary. So that's what we call an axis. So in this case, it's a hypothalamus pituitary thyroid axis. It's supposed to be in that box, but HPT axis is what we're talking about when we talk about how these things are connected. And it's that conversation that's happening between the brain and the thyroid that's critically important. When that starts to break down, that's when lab abnormalities start to show up and we can see issues with things like TSH and other things. Is everyone good so far? All right, so now we're going to dive into a little bit more detail. All right, so we just said the hypothalamus gland triggers the pituitary, and it does that through thyroid releasing hormone, something called TRH. We don't measure that a lot. Sometimes when we're working up issues with the hypothalamus and pituitary, we do, but that's not oftentimes something that we analyze. That causes the pituitary then to release thyroid stimulating hormone, which goes to the thyroid. And as I mentioned, when the thyroid produces its hormones, that feeds back up on the pituitary and turns it off. So there's that conversation that's happening all the time. The thyroid, in response, makes 95% of its hormone is T4. So that's the inactive form of thyroid hormone. 95% of it is T4, 5% is T3. So then the T4 cruises over to the liver and the kidney, and through the action of these iodinases, two different types of iodinases, it's either going to make T3, which is active thyroid hormone, or it's going to make reverse T3, which is the inactive form of type T3. That 5% of T3 then also goes down that pathway, and all together, the T3 is what's the machinery behind the thyroid. So when you're talking about what is the thyroid actually exerting itself through, it's through the mechanism of T3.
I have a question.
Mhm.
So when the thyroid sends the T4 over to the liver or kidney, what's going to happen with those? My question is, what happens? Can it affect digestion, kidney function?
Can the thyroid hormone itself?
Yeah. If there's too much or too little.
Absolutely. You're kind of on the next slide.
Oh,
Did you see
okay.
my presentation? So yeah, that it does. It's going to impact that. And if you have kidney and liver disease, bad enough kidney and liver disease, you can obviously have problems with this conversion process, right? If you were in liver failure and kidney failure, your thyroid function isn't going to be that great. Kind of the least of your worries if that's the case, but it definitely has a role in that. So ultimately what we want to do is get to T3, and T3 is the driver. So everything that thyroid is doing in the body is you're feeling T3. T4 is important because it's making T3, but it's not the main hormone that we're interested in. So when I'm looking at thyroid results, my eyeballs immediately go to T3. That's how I look at them. And we're going to talk about that in a second. So is this good? Are we good here? It's a lot of physiology, but I think it's important to understand how these things work together, because you just get thrown a TSH out there and people are like, well, I don't even really know what that means, And now you can say like, oh, that's a pituitary hormone. That's not even a thyroid hormone. So it's important to know. Okay, so here you go. What does it do? It does everything, basically. So thyroid, with its T3 and T4, basically regulates every function in the body. So it's going to regulate your heart function. It's going to regulate your blood pressure. It's going to regulate your digestion, how fast you digest, how slow you digest, everything in the nervous system, how awake you are, how asleep you are, how well your nerves work, all under the direction of thyroid. To a certain extent, bone health, your muscle contraction needs thyroid. So generally, your metabolic rate, your metabolism that you have for energy is all under the direction of thyroid. Not the only thing, but it's a big player. And then there's other hormones in the mix that are obviously influenced by the thyroid. On the back side of the thyroid, so if you took this thyroid and you flipped it, on the back side, there are these 4 parathyroid hormones. Can you see those kind of yellow, green? Those are our calcium regulating glands. They just so happen to be pasted on the back of the thyroid. They have nothing to do with the thyroid, really. All they do is, through the mechanism of calcitonin, regulate the calcium in our system and how that's used for bone, and then the kidney clearance rate. So this is where, again, the kidney part of this whole equation comes in. So this gland is a really active gland. There's a lot going on there, but essentially there isn't a part of the body that's not touched by thyroid function. So when we talk about autoimmune thyroid problems, I want to just kind of dive in here a little bit. My formatting didn't work here either. Put that over there. Over there. So there's essentially two different types of autoimmune disease when we talk about thyroid. One is called Hashimoto's disease, and the other is called Graves' disease. Hashimoto's disease is hypothyroidism that's driven by autoimmunity, and Graves' disease is hyperthyroidism that's driven by autoimmunity. So when I say autoimmunity, what am I talking about? What I'm talking about with autoimmunity is the body starts to develop these proteins, what we call antibodies. We make antibodies when we're exposed to diseases or illnesses, but what we should not do is make antibodies to our own tissue. We should not direct an attack of the immune system toward any part of our own body. We just want it to face into things that are foreign to us. When the body loses its ability to detect that a part of ourselves is us, it can start to attack that. And in the case of Hashimoto's disease, what's happening is we make these thyroid peroxidase antibodies. We also call those TPO antibodies that come over to the thyroid and through various mechanisms essentially shut down the function of the thyroid. They create an inflammatory response and they damage the thyroid, and the thyroid can't work very well. The majority of what we see in this country for thyroid disease is Hashimoto's. I've been practicing now for 20 years, and I can honestly say I'm seeing a lot more thyroid disease that's coming up that's not Hashimoto's disease, which is interesting to me. It kind of makes me think that there may be some environmental stuff at play. I'm not exactly sure, but it's not all autoimmune. And we're going to talk a little bit about the differences later, but that's what we're talking about with Hashimoto's disease. With Graves' disease, what's happening is we produce these antibodies called thyroglobulin antibodies, sometimes also thyroid stimulating immunoglobulin, TSI, and those actually come over to the thyroid and mimic the thyroid itself. So essentially what's happening is they are putting the thyroid in overdrive by participating in the manufacturing of so much thyroid hormone all at once. Thyroid stimulating immunoglobulin also acts like thyroid hormone, so it actually subs in for the thyroid hormone and creates sort of a hyper response of the thyroid. In either case, it's obviously very damaging to the thyroid because there's inflammation happening. There could be scar tissue, and the thyroid can become enlarged as a result of this. It can form nodules. So it's not a good situation to have happen, but it's not uncommon. So what are the symptoms of low thyroid? I mentioned Hashimoto's disease is the autoimmune version. When you don't have autoimmunity, we're talking about something called subclinical hypothyroidism. I don't know why it has that name. It's kind of a, I don't know, it's not a great name, but that's our word for not autoimmune hypothyroidism. So the symptoms are fatigue, weight gain, thinning, hair, dry skin, peeling nails, feeling cold all the time. So the person who's got like 6 blankets on them when everyone else is like, gosh, it's hot in here. Constipation, the slowing of the gut, periods can become irregular in menstruating women, depression, brain fog. I just can't think. I just feel like my brain is cloudy. And then if you have a fairly advanced state of this, an enlarged thyroid or thyroid nodules, the worst case of hypothyroidism I saw in my practice was actually a man, which is so interesting because hypothyroidism in general and autoimmunity is more common in women. But this particular man, he looked as though someone had literally unplugged him from the wall. He was sitting in a chair and he was so listless. He was literally like, if you pull the plug on a robot, how they just kind of go like this, that's what he looked like. He was so dialed down. It was very striking. And I didn't exactly know what was wrong with him. That was my first time seeing him, but he had a terrible case of hypothyroidism. And when we put him on thyroid medication, he was like a whole new guy. I hardly recognized him. There are other sort of more subtle signs of hypothyroidism, but these are the most common ones. As you might imagine, oh yes,
I have a question.
yes, from the hitherto world.
From out in the web.
Okay, great.
I'll do the best I can to slim this down, but if you could add or answer this question about the impact of TPO, if the higher the level, the more symptoms, and vice versa.
Not always. There is not a strong correlation between the level of TPO and the person's level of symptoms. However, there's definitely a correlation between the level of TPO and how much inflammation and disease is going on. So the person might not feel as symptomatic, but they are definitely in the background damaging their thyroid. So over time, that thyroid becomes less and less functional. So it still matters what your TPO level is, and it still matters that you follow it. We're going to get to that, but it doesn't always correlate. The thyroid hormones themselves, particularly T3, is the one. So for Graves' disease, the exact opposite. Now there is no other word for a hyperthyroid state that's not autoimmune. So we don't have a subclinical Graves or a subclinical hyperthyroidism, only hypo. So hyperthyroidism is by and large autoimmune. The exact opposite looking person. So very wired, very anxious. They can't sit still. They look like they've been at the coffee house all day, like chugging espressos all day long. They lose weight without trying, which is something that they actually many times like, and they don't want that to go away. But sometimes they drop 20, 30 pounds in a matter of a couple of weeks. Hair loss is common in this one as well. Sweating, I mean, they're sort of damp all the time. Loose stools, exact opposite of constipation. Irregular periods can be seen here. Insomnia, obviously, not uncommon. Palpitations and heart racing. And then the eye and eyelid symptoms. So this tends to be with really severe cases of Graves or Graves that has been around for a while. We actually start developing what we call proptosis, where we deposit proteins behind the eye and the eye muscles, and it actually pushes the eyeball forward, and then the lid can't close down on the eyelid. So you can imagine how uncomfortable that would be to not be able to close your eyelids, especially when you're trying to sleep. Your eyes get very dry. And in severe cases, it's, the eyes are literally bugging out. We call that a thyroid stare. People's eyeballs are very, very large. And you can also have an enlarged thyroid and thyroid nodules. The worst case of Graves' disease I ever saw, when I walked into the room of the visit, the woman's thyroid was so enlarged that I actually could see it thrumming. It was actually moving because her heart rate was driving it. And it was like a pulsating thyroid. It was the first thing I saw when I walked in the room. She actually also did have the eye changes that were associated with hyperthyroidism. So, I mean, these cases can be really, really devastating because a lot of times people don't know what's wrong with them. They think that they, have some sort of cancer. And, these are things that can be managed by the appropriate medications and the appropriate support. I'm not going to spend a ton. Yes, ma'am.
I have a question. Now, I'm hypothyroid,
Mm-hmm. Yes.
and I was never told I was Hashimoto's, but I noticed, and I can feel it.
Mhm.
It's like almost like a pulse going in my throat.
Sure. Yeah. Yeah. I mean, that's definitely, so you should know if you have Hashimoto's. So that would be point one that I would make. In other words, if you don't know, that's something that you should know, because we would manage that differently, and it would be important for you to manage that differently.
Because I've just gotten to a different
Mm-hmm.
endocrinologist,
Yeah.
and he's had me have a lot of blood work,
Mm-hmm.
and he also had an ultrasound.
Perfect. That was the second point that I was going to make. That would be something that I would want to have ultrasounded.
But I'm wondering, like medication-wise,
Mm.
I'm only on 1 milligram.
So you're stealing my
Because
thunder.
I was on.
We're going to have a whole med thing. You're going to walk out of here with,
micrograms.
yeah, it's micrograms. It can be million. Depends on the dose, but yeah, medications. Pandora's box is going to open. So stand back. You ready?
What does that mean?
That means you're going to have a lot of information. You're scared. You're going to have a lot of information about thyroid medication when you leave. Okay. And if you don't, then we'll talk. But I do want to go back a little bit to talk about factors that affect thyroid function, because where the endocrinology world falls down, and I love my endocrinology colleagues, but they don't think about all this stuff. They just think about like problem, medication. They don't even really care if it's autoimmune, because they figure there's nothing they can do about it. We look at it very differently. So I think it's important to know. So things that enhance the thyroid hormone production, so thyroid making thyroid hormone, things like iron, selenium, magnesium, iodine, probably heard of that one, tyrosine, which is an amino acid, and these vitamins, E, B2, B3, B6, CD. So basically a lot of the stuff that supports the thyroid is nutrition.
Should you take iodine if you have Hashimoto?
We don't know, but probably not high levels. We're also going to get to that. That's a great question. Things that enhance the T4 to T3 conversion, right? We want to make active thyroid hormone. We want this conversion to go well. Selenium and zinc helps that. And then we want to be able to take that T3 and get it to plug in its little docking station. So I kind of drew this little space. This is a cell, and every cell has receptors, little docking stations on them that are looking for thyroid hormone and a lot of other things, but thyroid hormone. And we want to be able to enhance that thyroid to dock there so that the actions of thyroid hormone can be carried out in the cell. So things that enhance the cell's sensitivity to thyroid are vitamin A, zinc, and also exercise. So there's a lot of things that you can do outside of medication that's going to make all this run a lot better, okay? It's not all about just the med. On the other hand, things that inhibit thyroid hormone production, stress, either directly through the action of cortisol or other mechanisms, infection or trauma, if you're hospitalized, that can cause it. Radiation, especially radiation to the thyroid or the neck. A lot of us in our age group have gotten those, lots of dental x-rays, those kind of things. Fluoride, because fluoride inhibits iodine and competes with it. Certain medications, toxins such as pesticides, mercury, cadmium, and lead, autoimmune disease, particularly celiac disease. And then things that enhance this pathway, T4 to reverse T3, stress, again, infection and trauma, very low calorie diet. So sometimes people with fasting, who are doing a lot of fasting, they can have that happen. Toxins, similar to above, inflammation, kidney and liver disease, again, through the mechanism from before, and then certain medications. So what ends up happening is if you make too much of this reverse T3, if you'll recall, you can make T3 or reverse T3. If you make a lot of reverse T3, what will end up happening is reverse T3 will occupy that receptor, that docking station, and it just sits there. It doesn't do anything for the cell. It just sits in the spot. And that,
I'm sorry, what's the purpose of
reverse T3, it actually does have some mechanism of action in the body. It does influence some action of thyroid. We just need to have the right balance. Yeah. So if we have too much of it, what ends up happening is it will sit there and it'll block the T3. So we check those levels, because a lot of times what will happen is people will be like, well, I'm on this medication and my T3 value is actually fine, but I still don't feel it. Like I don't feel like it's fine. Sometimes if you have a high level of reverse T3 or high cortisol or other hormone imbalances or nutritional deficiencies, you're just not getting the mileage out of your medication that you should.
when you've been told you're a poor converter,
Mhm.
so you're not taking, you're getting T4 even in medication. and
That's
it's not coming
this.
with it.
Yeah, that's this.
Is that associated with one or the other of the thyroid diseases, like more with autoimmune or more with
Mm,
subclinical? Or
I can't definitively answer that question,
I
to
was
be
just
honest with
curious.
you. I think it happens I think it happens across the board in some people, and I don't know who the person is that's going to be a bad converter. But that's why you want to know what your T3 and T4 are, because if you don't know,
Yeah.
you're
Well,
really
one
kind of
the reasons
operating
it
in the
took me
dark.
ages to find a DO who was finally like, yeah, your T4 is fine. I don't think it's turning into T3 like it's
Mhm.
supposed to. And then I was
That
like,
was a very smart
I don't
doctor.
like when I'm,
Those DOs are so
yeah.
smart. Did you have a question?
I just found out I get these newsletters from like Harvard Medical School and
No kidding.
But the only thing is that it's very interesting, like the parts, like the fluoride.
Mhm.
I have well water,
Mhm.
so I don't have to worry about that. But city water, how do they adjust it and how
Oh boy.
people that have hypothyroid or
How much
whatever-
time you have?
But biotin too. I was taking this stuff for your hair and
Mm-hmm.
nails, and the biotin you aren't supposed to have either for.
Yeah.
That was in one of the news.
Yeah,
just
that's not
recently.
necessarily
It's just-
true.
That biotin just interferes though with the test.
Correct. Yeah, that's the difference. So it will interfere with your levels when you test, but it doesn't interfere with thyroid function. In fact, you see that's B2, right? B3, sorry, B3. So yeah, I mean, you want to have biotin in your body. Your body has biotin in it. Fluoride is a big, huge topic, and I think there's way too much fluoride. I also think there's way too much bromide. I mean, bromide is in every baked good out there, and that's a competitor. They're on the same row of the table of elements. So there's definitely a lot of the bromide fluoride stuff that's out there and I was sort of talking about that earlier where I said there's something else going on here besides hypothyroidism that's autoimmune. I think that's a lot of what it is.
With the bread too.
That's the bromide because it's a leavening agent. It's in flour. It's in all kinds of stuff. Yeah.
Has it increased, has hypothyroid increased? Like, I don't know, I read some
Mhm.
in one of those articles or whatever that it really has flourished.
Yeah.
After, I can't remember if it was 1940s
Mhm.
or.
When bromination started. Yeah. When fluoride became a public health situation. Yeah.
But why isn't something done about it? Like, look at all the kids and everybody eats bread.
Well, they're not listening to us.
If they could make bread without it before,
Yeah.
why have it?
Mass production. That's what it comes down
You
to.
know?
There's too many bread eaters. That's the main problem. No, I'm kidding. That's oversimplification, but these are problems, and this is not supposed to be like overreaction kind of thing.
Yeah.
But if you can eliminate some exposure to these things, do. I mean, I don't use fluorinated water or toothpaste, or just try to get some of it out. You're not going to have zero, but try to get some of it out of your system if you can. Okay, so this is a lot of information. Oh yeah.
If you're having like a serum T3
Mhm.
drawn or whatever, is that going to include the reverse T3
No.
in the level?
Nope. You have to order it separately. It's totally separate. Yeah. It's a good question. Be great if we could just sort it out, like take the T3 and do a certain ratio, but no, that's not how it works. All right. So evaluating thyroid symptoms. So this is where the traditional medical world and the functional medical world radically diverge. So you can see over here in the traditional approach, and this is a generalization, right? There are doctors in the traditional world who are open, the DO that does T3 and T4 measurements. Some people do thyroid antibodies. So again, very oversimplified discussion, but mostly you're going to get a TSH in that environment. That's it. And if you have a normal TSH, you don't have hypothyroidism, you don't have a thyroid problem. Sometimes they'll throw in a T4, but that T4 is not the active thyroid. So it's not really helpful, right? They don't do the T3. For some reason, that just is a sticking point. So TSH. Over here in the functional medicine world, obviously we check TSH too. We also do free T3. Sometimes people do total T3. I've seen both. And I typically stay with free T3. That's just how I've trained, and that's what I use. Free T4 also. We kind of want to know what the balance is, make sure the T4 is there, or total T4. There's your reverse T3, a separate orderable, and then thyroid antibodies, thyroid peroxidase antibodies, thyroglobulin. Now, even if a patient is presenting to me with a very obviously hypothyroid picture, they're not Graves, they're not a hyperthyroid patient, I still check thyroglobulin, because sometimes what I'll see is they'll either have both antibodies or that they may actually be on the very tail end of a mild Graves' disease that has now converted over into hypothyroidism. So sometimes I'll actually see people who have both thyroid peroxidase antibodies and thyroglobulin antibodies, but they have low functioning thyroid. And I think they were probably just not caught back when they were feeling good. They're like, I have so much energy, I feel great. And nobody bothered to go to the doctor because they were feeling good. Did you have a
I
question?
had a question about
Yeah.
that when you first brought that up.
Mm-hmm.
Because I was under the impression that either the TPO or thyroglobulin antibodies could be Hashimoto's if you had an elevation of either one.
Right. With the right numbers here, yes.
Yes.
Yeah. With a hypothyroidism looking picture,
Right.
yes.
Okay.
I would keep an eye on both.
Yes.
because
I both checked, but
yeah.
thyroglobulin is the one that's always.
Yeah. So there are people like that. Yep. It's really interesting. Yeah. There are people who have thyroglobulin and they're hypothyroid. And again, my theory, and I don't have any literature behind this, but my theory is that there was an autoimmune hyperthyroidism that then converted into a low acting thyroid gland by the time it's caught. So they still have thyroglobulin antibodies circulating, but their thyroid it's kind of been impacted by it.
And then it's treated the same no matter which type of.
You're treated like a
antibodies?
hypothyroid patient.
Right.
By that point. And a lot of times my Graves patients, who, especially those who've had Graves for a really long time, they ultimately end up just burning their thyroid out. Some of them actually go through radioactive iodine treatment, so it completely obliterates their thyroid function, and then they become a hypothyroid patient. I actually have a couple that swing both. Like sometimes they're hyper and we're treating them with methimazole and all kinds of other things, and sometimes they're hypo and they move back and forth depending on which antibodies are present. You have to really hang in there with those people. A lot of the endocrinologists won't do it. They just won't. They're like, you're a Graves' disease patient. We're going to treat you like Graves. We're never going to give you thyroid hormone. So, and then thyroid stimulating immunoglobulin is just for Graves. We don't check that if you're hypothyroid, just because it's never positive. It's always sort of lurking in the background for Graves' disease. But there's more. Oh, not a whole lot going on over here. But in the right patients, looking at adrenal function, cortisol, DHEA, our stress hormones, really important. I'm going to talk about why that is. If you're a female, estrogen, progesterone, and testosterone. If you're male, testosterone, sometimes also estrogen, progesterone. But urinary iodine level, I don't know where you stand on this these days, but iodine has gotten this. It's kind of like vitamin C and vitamin D is like a lot, it's not a lot. I mean, it's been all over the political map as to whether or not iodine is a good thing. I think correcting iodine into the normal level, if it's low, makes sense. I don't think mega doses of iodine is a good idea. It can flood the thyroid in an autoimmune disease. It can actually hamper immune function. So you don't want to just go out and take a fistful of iodine and go like, well, I have thyroid problems, so this has got to be good for me. That's not true. I've never believed that to be true. There's been books written about the fact that you can take as much iodine as you want. I just have not seen that, and I see it backfire. Is that what you see, Dan? Yeah.
I agree.
Do they test for that?
Who's they?
Well, when you go to the doctor and they do blood work.
Oh, heck no.
I mean, how do they know? Like how would
You're going to be smart and you're going to ask for it.
You know.
You're going to go in and you're going to say, I would like to have a urinary iodine level done, please.
Yeah, and hopefully they don't tell you, I see no reason to do that.
Yeah, we'll say, I do.
With the urine?
Yeah.
Now.
You can do it with the blood, but
urine's.
urine's...
Urine specimen done in years. And I asked why. And they said the insurances don't think it's important.
But how many insurances are run by physicians? That's what I would like to know. How many physicians are running insurance companies? I'm trying not to be so political, but I just can't help myself. So yeah, it's important to know. If you have an iodine deficiency, you should correct it. Thyroid support nutrient levels, selenium, magnesium, iron, those things that we talked about. It's a little hard to do a tyrosine level. It's not impossible, but it's not easy. But at least at least you should know where you stand, because you can correct deficiencies and it'll help your thyroid work better. We do genomics in certain people. And then focusing on the whole person. We want to look at your nutrition, your exercise, your sleep, your stress. We want to pay attention to all of those things when we're devising a plan, because we're not just going to focus on like, here's your med, here's your supplements, out the door you go. We want to look at the whole person and try to work with all of the things.
How do you do that? General, whatever.
How to what?
You test for that?
Test for what?
What was it? General?
Genomics? Yes, we test for that. It's a saliva or a swab of the inside of the cheek or a saliva test.
Oh, because I have to do that for 2 days in a row, but that's just for cortisol.
Oh, that's a whole other topic. Yeah.
But should I ask for that one too?
I don't think you're going to get very far with that one. I mean, you could, but you're going to get some head scratching probably on that one. Yeah.
You're testing urine for iodine.
Yeah.
Are there symptoms?
Symptoms of low iodine?
Urinary.
Oh.
Something you would feel?
Oh, no. So you're thinking like urinary symptoms?
Yeah.
No, it doesn't feel like a urinary tract. We just like to collect it from the urine because it's just a really great way for us to get at a really accurate level, as opposed to the blood levels, which aren't as accurate. It's just the best way to assess how much iodine you have in your body.
Saying having an iodine level that's off isn't going to create a symptom
No.
in a person.
No.
Okay.
No. It'll create a goiter if it's really bad.
Yeah, it has nothing to do with urinary.
Yeah, no. So here's Elizabeth. Remember her at the beginning of the talk? So here's what she looked like. Is it kind of fuzzy? Yeah, that's this big screen. So here, I want you to look at this like I do. Okay. So don't look at the abnormal level. You're so smart now. What you're going to do is you're going to go, what's the T3? I want to see the T3. Well, let's look at her T3. It's 2.5. The range is 2.5 to 6.5. That's not so hot, right? Even though it's not being flagged as low, it's still pretty dang low. Okay, that's T3. That's a really, really important one. T4, let's go to that one. This one has a total and a free. Here's her total, 5 to 10.8. Here's her free, 0.7 to 2.5. Again, kind of low, right? So because of that, she's actually high, by this test anyway, on her TSH. When she was at the primary care doctor and it was a 5.2, they didn't have all this information, but they were like, oh, it's actually in the normal range. It's fine. The top limit of TSH has also had sort of historical swings. There's been times where, it used to be 5 and then it was 5.5. And then some people started to say, well, 3 is really it. And it's 2.5. I don't get too hung up on that. What I want to know is, does the TSH and the T3 and T4 match the person? How does the person feel? The numbers are just informing how the person feels. So they're not all that we're looking at. It's not all about the numbers. The numbers have to go together with how the person feels. So if your TSH was 5.2 and you're like, I feel great, then I'm like, okay, you don't have a problem. If you feel like you're Elizabeth, then you probably do have an issue. She does not have thyroid globulin or TPO antibodies, so she's subclinical. And her urine iodine was 103, range is 100 to 380. So she would probably do well with a little bit of iodine. This particular panel is not the whole whopping thing. I thought we'd be here all night if I put that one up. But, we'd be looking at her selenium, magnesium, iron, probably her cortisol, maybe some hormones, et cetera.
But what's interesting to me is that left side typical doctor goes, oh, they're all within the normal range. You're fine.
Yeah. So
And that's what I had for
again,
years.
right.
I like that I don't feel
Yes. Listen to the patient, right? The person can tell you what's going on. I mean, I can call it across the room, because even if the T3 is in the normal range, if they look like Elizabeth, I'm going to treat them. I mean, we're going to talk about it, but they're going to feel better on thyroid hormone. They're going to feel better on nutritional support, a little iodine, et cetera. So, we know what's going on with our bodies, right? We know what to look for.
Because you're like saying we're all individuals.
This is true.
And the symptoms that you have are more important.
Yes, the symptoms are
Because
critically
when I was
important.
first diagnosed, I didn't even know. The doctor, he ran the test, Dr. Cleary from Oconomowoc years and years ago, like 40 years ago. and I was in the normal range, and I was dragging. I mean, going up the stairs, I thought I was like having heart problems.
Yeah.
Out of
Yeah, it gets missed a lot.
And he said, just let's wait a couple of weeks and try it again. And he said, can you handle it? And I said, yeah, let's do it. And that's when it showed it was in. So I was really drained.
Yeah.
And I was still.
Yeah, that's the purpose of this education, is because I want you to understand that what you know and what you feel is important, and your doctor should be your partner. They should be your boss. They should be your partner. They should be working with you. They should be listening to you. It should be a collaborative relationship. So if that's not happening, I always say, like, find a new doctor, because that's not okay. You know, people walk around with all kinds of terrible diagnoses that shouldn't be. Anyway, politics. Okay, let's move on. All right. So treating hypothyroidism. Again, we put Graves off to the side. It's a much more complicated disease. We have opportunities, obviously, within functional medicine to help those folks, and I have them in my practice, but less of them, much more hypothyroid. So treating. If you go to the doctor in the traditional world, typically what you're going to be presented with as treatment is Synthroid and levothyroxine. Synthroid is brand, levothyroxine is the generic version. And that's pretty much it. That's what they work with. The endocrinology crowd, same. They pretty much, that's their world, or those two medications. In the functional medicine side, yes, we use Synthroid and levothyroxine in some patients. Some people feel great on it. They take that, that's all they need. They go on their merry way, they feel fine. Levothyroxine and Synthroid are straight T4. So you'll remember, T4 is not active thyroid. It's the precursor to T3. So somebody asked me about conversion. Yeah, so the conversion to T3 in some people just doesn't work well. It just,
blood level. Like, oh, you got a great amount of T4 in your blood.
yeah, how about that? Not doing anything for me. So that's why sometimes we add cytomel and liothyronine, which are direct T3 to the regimen. We put those two together. Every so often I'll have somebody who just takes T3. They feel better. We can also do combined T3 and T4 medications. These are the names of those: Armour, NP thyroid, Westheroid, Natrothyroid, all, in my mind, for there's slight differences, but for all intents and purposes, the same kind of medication. They're derived from pork thyroid. It's an FDA-approved medication, even though that sounds really weird. Like, pork thyroid is an FDA? Yes, it is. It was the first thyroid medication before the synthetics came along. So we used pork thyroid to treat thyroid. And it's T3 and T4 in a fixed combination. So in every grain of thyroid that we take, or grams of thyroid that we take, it has this much T3 and this much T4 for each of those. If that doesn't seem to work well, and we can't kind of get the balance right, and we kind of drive things up and drive things down, then we can actually compound thyroid medication. That's what Dan and his team do here. We can make our own thyroid medication for an individual with T3 and T4 at whatever milligram doses we want, microgram doses we want. And we can make it in an immediate release capsule, so it breaks down and is released quickly, or a sustained release capsule where it sits in the system and is released slowly into the body. Sometimes people take both. Sometimes they take a sustained release in the morning and immediate release in the afternoon. I mean, all of this can be combined in different ways. It just goes to show you that somebody asked me earlier about treatment. What was that? Was it over here? Like, I don't remember. Somebody said something about treatment, but you can see there's like a whole repertoire of thyroid medications that you can use. And my feeling is you should continue to try and experiment with these, with the doctor, of course, until you find one that works great for you and makes you feel good. You should feel normal when you're on the right medication. I mean, we're all kind of like not abnormal, but you know. So there's lots of options here. And I think it's important to have a doctor who has an open mind, who can present all of those options to you, and then you all decide together. And there's more.
Just as expensive as taking like the Synthroid,
Which one?
like whatever.
The majority of these are all covered by insurance company to varying degrees. Compounded is generally not covered by insurance, but it's not very expensive. $30 a month. So yeah, these are all pharmaceuticals that you can get at your pharmacy anywhere. So
So you mean for $30 a month, I could feel better?
that's all it takes. $30. That's the best part of this evening. You found out it only takes $30 to feel good.
I'm paying, I mean, out of pocket.
Yeah, you got to talk to Dan.
Before,
You should talk to Dan.
He's
No, these are not expensive.
$100 and some dollars.
If you buy any of these out of pocket, these are cheap meds generally. If they're hiked, it's because the pharmacy hiked them.
Because when I took the generic? Don't ask me. I asked a lot of different pharmacists, and I had to pee so fast. It's for some reason, whenever I went on that, because they'd say, oh, there's no difference. And I'm not kidding.
Well, clearly there
something
was.
about it
Yeah, clearly
didn't
there
agree
was.
with me.
Yeah. So that's, yes, there you go. All the more reason why that wasn't the right choice for you. Yep. All right. So what else should we be doing to treat hypothyroidism? If you have autoimmune disease, Hashimoto's, there's a great deal of evidence to suggest that gluten-free diet is helpful to lower antibodies and preserve thyroid function. It also impacts one's ability to hopefully not develop other autoimmune diseases, because once you have one autoimmune disease, you are at risk for other autoimmune diseases. So taking gluten out of your diet can be helpful. An anti-inflammatory diet in general, and that's a big topic, but what are we saying? Whole foods, things that you recognize as food, stuff that comes from a plant, not from a plant, and that are high in nutrient value, not preserves, not preservatives, not a lot of junkiness, but things that are really, really what I call the great-grandmother diet. If your great-grandmother came back and looked at your plate, she would know what you're eating. Low-dose naltrexone, a whole other topic as well. There's a book over here. I love this low-dose naltrexone book, LDN. LDN is a really interesting medication. So naltrexone is the medication that we use when somebody overdoses on opioids, when they have a heroin overdose or they overdose on pain medication. We administer naltrexone, which is brand name Narcan. We give it to people, we put it in their nose, we get it however we can. And people who have overdosed, pop up it's crazy to watch this. That is a naltrexone dose, 90 to 100, 120 milligrams. When we're talking about low-dose naltrexone, what we're talking about are very tiny doses of naltrexone, 0.1, 0.5, 1, up to like 5 milligrams. And that dose of naltrexone has a very interesting impact on the immune system. And it actually immunomodulates, meaning it actually changes the body's ability to create those antibodies that are attacking whatever system. So it's not just specific for thyroid. We use LDN and other autoimmune diseases. We use it in all kinds of stuff. But it does actually lower the antibody count, which is really interesting, in both Graves' and Hashimoto's, and not in every patient, but some. I've had some really good success stories with patients who had terrible, thyroglobulin or TPO antibody levels in the 500s, 600s, 800s, more. And we were able to actually normalize their antibodies with a gluten-free diet and low-dose naltrexone and just really appropriate thyroid treatment. So it does work really, really well. It's kind of a cool little molecule, and it is compounded. You can't buy this off the shelf. You actually have to have a prescription for it, and it has to be made at the low dose. So just for whatever that's worth. Nutritional support, obviously, we talked about iodine quite a bit. Iron, selenium, magnesium, tyrosine, omega-3s, and turmeric, which is anti-inflammatory. Any of the anti-inflammatories, ginger, turmeric, boswellia, all of these great anti-inflammatories that you can take that are great for inflammation. Caution also in selenium. Selenium is in the soil, and it varies widely across the state, across the world. Like, I could have lots of selenium in my soil in my garden, and my next door neighbor literally doesn't have the same amounts. And so I might actually have a normal selenium level and they might have a low level, but you can get selenium toxic. So you don't want to just start pumping selenium in. You actually do need to be careful with how much selenium you're taking. So again, measuring, knowing where you're at, following, all of those things are really important. Not just supplements, but also food that you can use to support your thyroid. So selenium is present in this is not the whole list, but these are the biggies. Eggs, oats. These are Brazil nuts. Brazil nuts are like my favorite thyroid support food. Just a couple of Brazil nuts packs a great punch. It has magnesium and all selenium. And it's interesting, if you take 2 Brazil nuts and you stick them next to each other, they actually look like a thyroid, which is kind of cool. So, and all you need is 2. That's all you need.
It's funny, when I was really young, those, like my mom would have mixed nuts.
Yeah.
I would eat all the Brazil nuts.
You must have known something.
No, I'm thinking, now this is just a theory, but I think if you leave a child, like, I never cared for milk either.
Mm-hmm.
there's something in the body that I think a child knows what they should have. and
Yeah,
they should,
intuitive.
They should be brought up that way.
You're right. Except if they don't like vegetables, in which case they're wrong. Okay, so iodine is in seaweed and kelp, obviously, eggs as well, dairy foods, tyrosine in meat, not just red meat, but chicken, pork, seafood, tofu if you happen to be vegetarian or vegan, and then nuts and seeds. Iron is in lentils and legumes, also meats and leafy greens, and then magnesium in leafy greens. Nuts, particularly these little pepitos, these pumpkin seeds, really nice source, and then avocados. So there's a lot of great foods that if you're eating regularly are giving your thyroid a lot of health.
The, what do we call it? Blue algae that's
Mhm.
often spirulina.
Mm-hmm.
Is there iodine in
Is
spirulina?
there iodine? I don't think so, but I could be wrong.
I just wondered. 'Cause-
Dan's going to look it up.
yeah.
We'll have an answer for you in a
I mean,
moment.
it's
Yeah,
related.
I think it is, but I
But I
don't think
think
there's
maybe it's
iodine
in
in it. But let's double check on that. It's a great question. Okay, so I alluded to earlier how stress and other hormones interface with the thyroid. And here's how that works. So you guys remember hypothalamus, pituitary, adrenal. Here's the adrenal glands sitting on top of your renal kidney, adrenal on top of. And there is an axis here as well called the hypothalamus pituitary adrenal axis, HPA axis. There's a conversation happening there as well. So here's how it works. If you're stressed by something, you have a fight or flight response. Your adrenals release adrenaline, noradrenaline, that like butterflies in the stomach, dilates your pupils, makes you see better. You grip the steering wheel if somebody's cut you off. Your muscles become stronger. You can run away from a predator. That is an acute stress response. In a chronic stress response, what's happening is the hypothalamus and pituitary are making ACTH, which is coming down to a part of this adrenal gland, and they're producing DHEA and cortisol. Cortisol is a stress hormone. Cortisol has gotten a bad rap because everyone thinks that it's a terrible, terrible thing for you. We actually need it. We need some of it. And so when you actually look at people's cortisol levels throughout a day, it's actually high at times and low at other times. Why would that be? Well, it actually serves as an anti-inflammatory in the body in the right amounts. So if you're running away from a tiger and the tiger snags you with its fingernail and it cuts you, you have cortisol around then as your backup after that adrenaline goes away to start healing the wound so that you survive. That's its job. So if we have enough of it, fantastic. If we have too much of it or too little of it, that's when things start to get to be a problem. And that's when people hear about cortisol problems. We're talking about too much or too little.
Are you seeing reductions in cortisol in post-COVID? People who have had COVID?
Are you saying that their levels are low?
Are low.
You know what? I don't know that I could universally say that. It would make sense because people who are very ill would have a real significant stressor and that would impact their cortisol. But I don't know of any like across the board link between COVID and cortisol being low. I'm certain it impacts cortisol, but it's going to be really interesting to see what role cortisol plays in this long hauler.
Yeah.
Yeah. Yeah.
To be kind of stuck there, and I've got low cortisol, and my blood sugar has gone up. And all of the
There's so much we have to learn about this.
Yeah.
There's so much, and nobody
Trying to
really.
figure out what's still post that.
Oh, I know, right? It's so hard. So hard to sort out. But good for you for knowing those data. That's really important. So then what ends up happening is if you have stress, it doesn't just compartmentalize. It's not like when you play that checker game Connect 4 and you stick a checker in the top and it goes down and it's going to land in one column. There's impacts across the system. Hormones by their nature are conversation molecules. They're talking to your body. They're talking to each other. So if a stress response occurs here, it's going to occur in other axes as well, right? And not only that, but cortisol actually has an inhibitory effect on TSH directly and also on that liver and kidney conversion from T4 to T3. So there's a direct correlation, but then there's also this hypothalamus pituitary feedback axis thing that's happening as well. So in somebody who's fatigued and has weight gain and has their hair is changing and they're like, I've gained weight in my middle and I can't figure out why, it's really hard to tell sometimes whether it's a thyroid or a cortisol. So I always end up looking at both because there's just so much more information. If you have both, you should be addressing both, treating both. So the traditional medical world, unfortunately, doesn't do a lot with cortisol unless you have Cushing's or Addison's disease, which are the extremes of those. So this is something that I think functional medicine does a really good job of treating and diagnosing. In terms of sex hormones and thyroid, it's kind of a simplified slide, but estrogen increases thyroid binding globulin. That's a new one. So what is thyroid binding globulin? Hormones are fat. So they're on a fat backbone. They're actually made out of cholesterol. So they have to travel in the bloodstream attached to something. Otherwise, it would be sort of like an oil and water situation. You know, they would float out of the blood and cause problems. So they attach to a protein in order to be able to surf around in the body. In the case of thyroid, that's thyroid binding globulin. So estrogen increases thyroid binding globulin. It can lower TSH and increase T3 and T4. Now, if you're a person who's menstruating, your estrogen levels are changing throughout the month. So it's not like it's going to shift things drastically. But if you are struggling with your thyroid, but you're also having a pretty severe hormone imbalance, it could get in the way of how well your thyroid works for you. And then progesterone and testosterone exert their imbalance and in the decreasing the thyroid binding globulin, so not as much can be carried. So it's important to know, and again, in the right person who's exhibiting hormone symptoms. In the case of Elizabeth, she had these irregular periods and the no periods for 3 months. We'd want to know what her hormone status was. All right, so here's the genomics thing. It's a lot of stuff to look at here, and I'm not going to get deep here, but I just want to point out that autoimmune thyroid disease is believed to be 68 to 75% hereditary. That's a lot. That's a lot of hereditary. So they've begun to unpack, now that we have the Human Genome Project, these particular genes. These are gene markers, and these in Graves' disease, and there is an association. So now what they're trying to figure out is what are the patterns that people have with these genes and how do they get expressed? What are the things that are causing them to be expressed? Is it an environmental thing? Is it a virus? Is it nutrition stuff? Is it stress? Is it all of the above? Is it fluoride? Is it bromide? Like what's causing these things to happen? So we don't do genetics on everybody, but I'll tell you one of the things I've really become interested in is this DIO1 and 2. DIO1 and 2 are interesting because they're enzymes that are expressed in the brain. And so when people have a hard time feeling better mentally when they're on thyroid hormone, they have hypothyroidism, for example, their numbers look great. I mean, you know, their T3 is 3.5 and, you know, they look good, but they're just like, my brain just does not feel like it's treated. Those are people who typically have DIO1 and 2 gene problems, and we actually have to increase their T3 higher. We have to push it up in order for them to feel better because they just don't convert that well in the brain. So it is helpful in some people to know, especially if they feel brain fog or they feel mentally like they're just not there with their thyroid. There can be a whole host of reasons for that, obviously, but that is kind of an interesting thing to look at. So a little, shameless plug. What is Vital Health? We are actually a company of functional medicine physicians that are available in telemedicine. Now, last time I was here, I think it was late 2019, telemedicine, I got a lot of stares from people. They're like, what's telemedicine? Now that COVID has happened, pretty much everyone's had a virtual visit, a telemedicine visit with their doctor. So we only do virtual visits. We do not have a clinic. We do not see patients in person. Our consults are long visits with people. We have a completely beautiful, safe electronic medical record that does functional medicine only. And so all of our doctors are available online. We have doctors from all over the country with different levels of expertise, different interests, different things that they do. So it's a great way to receive care because you don't necessarily have to get in your car and drive to Colorado or something. We have a whole bunch of docs that are incredibly talented of all different types, MDs, DOs. We have naturopathic physicians. We have a whole different offering depending on what jives with you, what you're interested in, kind of practice you like to have. And then how it works. So you don't have to take our symptom quiz, but you can take a symptom quiz if you're not sure if you have a hormone imbalance, a thyroid problem, a gut issue. You can take our symptom quiz online. You can book your appointment right online. You meet your doctor in the computer so you can be in your house. And I love this because I now make house calls. I've never made house calls before in my career. And now I make house calls through people's computers so they can take me into their kitchen and show me all their supplements that they're taking. I see their cats, their dogs, their kids. It's really cool. And it could be fun because the kids get there and they want attention, and then we play a little bit. It's really fun. A lot of our testing is done at home, not all of it, but much of it is done at home, either through a saliva, urine, stool test, finger stick blood tests. I think that's it. Yeah. And then we maintain ongoing relationships with patients through our telemedicine practice. So it's not a one and done. We're not like, okay, here's your diagnosis, good luck. We actually see patients ongoing. We have long-term relationships. And that was when we first started, that was a really odd thing to do. Like, oh, you can have a relationship with a doctor through the computer. Yeah, it works really well for this kind of stuff.
How's the insurance piece?
We are out of network, so we don't accept any in-network insurance. However, a lot of people get reimbursement for their out-of-network benefits. So we'll give you a super bill, which is all the insurance talk, and you can submit it, get reimbursed. We also accept HSA and FSA. So if you have a high deductible health plan, you have an HSA and FSA account, everything is covered with that.
I have another question. I don't know if you're, so we have a problem in this culture with, as you're aging, you bring stuff up and it's, you're getting
Oh,
old.
I know. I get that.
I put you in, what was one of the last things, my doctor retired, but she said, you're in the geriatric class now. What did you just say?
Geriatric class?
It was like I'm geriatric.
She's class to geriatric patient.
Yeah.
Oh,
Yeah.
that's mean.
There was a
Yeah.
geriatric pregnancy at 38.
39.
Geriatric.
Advanced maternal age. I'm like, advanced maternal age? 39? Come on. Yeah.
Give me 39, please.
Yeah, right. Exactly. So, yeah, that's, I think what has to happen, can you take me off camera? No, I'm kidding. I think what has to happen is the old guard needs to move on, and the new guard needs to come in and say, this is how we treat patients. They are our people. We have a relationship. Our job is to help you. It's not to dismiss. What other questions do you all have? You guys asked some really good questions.
I had
So
a question.
yeah.
At the end there, when you were doing that last little section on the like the sex hormones, estrogen,
Yeah.
testosterone, all that, and you were referring to the carrying.
Yeah, the thyroid binding globulin.
Yes.
TBG. Yep.
So, how does super low testosterone affect?
Well, testosterone is carried by sex hormone binding globulin, so so it has a different carrier protein, and so it's not going to directly impact it's going to directly impact the thyroid binding globulin. It's going to decrease it, but you're not going to have that testosterone impacted by its own binding carrier. So it's still going to circulate as long as that's normal.
So if you have a lot of the symptoms,
Yeah.
that are like right in line with the list for thyroid
Mhm.
dysfunction, but your thyroid numbers are not they're not really nice and high, or but they're low but not super low.
Yeah.
But your T is like less than 2.5.
Mm-hmm. Are you talking about a woman or a man?
Me.
Oh, okay.
Are you looking more at just increasing that? I mean, are you still going to look at
Yeah.
Right.
Oh, so I call those two opportunities.
Yeah.
You'd want to address the T, and you'd want to address the thyroid. So even if the thyroid's borderline, why wouldn't you try and see if you nudge it up and see if you feel better.
I mean, I know you're not here to diagnose.
No,
but
no,
would you
but-
look at my numbers tonight if it were you, or can I make an appointment with you?
Absolutely. Absolutely, yeah. I try not to render medical diagnoses when I'm not
Right.
your doctor because,
Yeah, I mean,
Yeah.
I just went through, I have a great nurse practitioner, but she's in Madison.
Mm.
And hard to get in to see her.
Yeah.
Drive. And I just went through thinking, well, I really just need to get a local doctor
Mhm.
to have that doctor that you list as your,
yeah.
and I felt like I needed a referral to an endocrinologist. And so I went to this doctor and, was real specific about my history and all the things and even a printed thing so you couldn't forget all of it because you don't have time to write all that down. I don't absorb B12. I have to do injections. So all those things, I really would like further cortisol testing and an endocrinologist referral. And they looked at all my blood work and then just said, oh, your B12 is low normal and your D is low normal. Take a vitamin. Like, just take a vitamin.
Go to the drugstore
That,
and get a
and not even
multivitamin.
how much
Oh.
to get my level. And I think the bill before insurance negotiates their reduction was like $4,000 after all the lab costs and the doctor visit. And my cost after insurance is now $1,300 for this physician to tell me to take a grocery store multivitamin.
Well, yeah. Yes, and I could curse. I'm not going to.
Yeah.
But where is it, by the way? Oh, there it is. So that's terrible. And to pay $1,300 for that
Yeah.
is
No,
highway
no, like,
robbery.
okay, so this person didn't see what they thought these blood tests were going to show. And when they didn't see it, it's like, well, there's nothing here. Let's explore this further.
Yeah.
Why do you
Yeah.
feel so bad?
You can't possibly be right, you the patient, right? Like, yeah. No, I hear that so much. Now I'm the deck is stacked because, I do functional medicine. So I get frustrated people who've left
Right.
traditional medicine or are only using it for what they absolutely have to use it for. And I use traditional medicine. I know I've bashed it a lot tonight and I know I've made fun of it and I've kicked it and all that, but I have traditional doctors and I take traditional medications and I am a physician. So this is not about rejection of medicine.
No, my husband,
No, I'm saying it because in case this hits the internet and people are.
They saved my husband's life
Yeah,
last year.
exactly.
COVID-19 was
So
amazing, but
it's
in this
not a bad
situation, I was
thing.
not well served.
But that is not okay for somebody to treat you like that. So when I get asked, is insurance going to cover me? I say, well, no, but you kind of get a lot more.
Mhm.
When you're in the driver's seat, you get an hour of time, you get lots of hands-on, you get follow-up, you get tests that agree with you, you get a collaborative relationship. And I think that's what's going to happen is we're just going to have to uncouple all of this insurance stuff and make it more about you being in the driver's seat, which is why I like HSAs and FSAs, because they give you your own tax dollars and you get to play with them. You get to decide. If you want to go see a doctor and have that, great, take your $1,300 and go for it. But if you don't, then you have another option. And I think that's where that's how we drive the change, is to take our money and go like, this isn't working. I'm going to go over here and try this.
Yeah.
And it's not that everyone needs a functional medicine doctor. I'm going to correct myself. But I do think that, doctors just don't know, and they certainly don't want to look bad. They just don't want to look bad. They don't want to not know. So instead of saying, I don't know,
Yeah.
they just
all
won't.
I messaged her back and I said, look, I never expected you to know everything.
Of course
But when
not.
you
Nobody
didn't find
does.
An answer for how he's feeling, doctor, would you really have accepted
Yeah.
for this fee a prescription to go to the grocery store and get a vitamin?
Yeah. That's just
Yeah.
unacceptable.
She even brought up the possibility of apnea,
Mm.
and some other things, and then never even addressed it.
Oh, I'm sorry. That's horrible.
And said, "Oh yeah, I'm sorry, I forgot the cortisol test." And the referral.
It would have been a single value in the blood anyway, which would have been useless to you. So
Right. I had been given 3 very specific tests to request. And
yeah,
it was all ignored. It was all
Yeah.
written down, and it was all ignored.
that's not okay.
No.
Fire. Okay, Dan.
Online question.
Yes.
If we make an appointment,
Mhm.
but do not have recent labs,
Mm.
so just T3 and so forth,
Mhm.
will you order labs before the appointment so that the appointment is more productive?
Oh.
Consultations
That's a great question. I get that a lot, actually. So what I would recommend, even though it seems a little counterintuitive, is to not do the labs ahead of time, because during the course of the conversation that we have for an hour, we might find that there's a lot of things we want to look at, right? Not just the T3. We want to look at a whole bunch of stuff. So we really want to get the story, get the whole story, and then, okay, what do you have? What don't you have? Let's fill in the blanks. How old is your lab? When was this last done? Now we know you as a person and all your needs, and we can actually start saying like, okay, here's what you need to do, right? So it's not just about, I know it seems like, oh, I should do this first because then when I come to the table, I'm fully loaded, but you're not really. You're really just kind of scratching the surface. So I always prefer to meet with people, know their story, understand what they need, and then do labs. So I think you were next.
I'm hypothyroid, have been for years,
Mhm.
been on medication, and I developed AFib. Is there any correlation between the two?
Between hypothyroidism and AFib?
I have proximal. The doctor said because I'm over 60 and I'm female. I mean, I've had every heart test.
Huh?
I had no problem. Just had an echocardiogram again.
Yeah.
It's all normal.
I can tell you that in the right person, and generally it's an older person, not an old person, because you're not an old person. If you have the propensity to develop AFib, whether it's paroxysmal or it's whatever, and we put you on thyroid medication, we got to be careful, because sometimes T3, a little bit extra T3 will fire that AFib off.
Since I was put on T3,
Yeah.
I was on Armor,
Mhm.
and since I've been put on Levo and T3, I get it every month.
Yeah.
Of course, I don't know when.
Yes. So again, it's not like, oh, you're a woman and you're past this age, but it's you as a person, it might not be the right thing.
So it could be the T3.
Yeah.
that's causing
Yeah.
for me to get more. frequent.
Possibly,
Mhm.
quite possibly. Yeah.
Okay.
It's worth checking, right? It's absolutely worth checking.
I just had AFib from thyroid.
Ah, there you go.
I was on that compound medication, from you many years ago.
Oh, yes. Now that I'm looking at you,
And then you were gone.
I'm back. Poof.
So I went on natural, I went on AMP
Mhm.
for quite fun. But then all of a sudden it was raised.
Mm,
And then one day, I wasn't on for the higher one.
mm.
My heart was pounding
Yeah.
and going and going. So
Yeah.
I finally went into the emergency room.
Mhm.
So and my THA was 0.005 or something like this.
Yeah. When you take T3, it's often very suppressed.
So anyhow, they had me on all kinds of stuff and was in ICU for the whole
Wow.
night, and finally it got.
Hmm.
And then when I was released from the hospital, they got me an endocrinologist
Mhm.
and cardiologist and everything else.
A lot of ologists, yeah.
But anyhow, they went to the endocrinologist, and then I came up with, now I am a levothyroxine.
Hmm.
They had 50 milligram, right? And then I just had blood work done, and it was 5. So now it was increased. So
You're back on the carousel, right?
So Hashimoto doesn't matter. T3 doesn't matter. T3 reverse doesn't matter at all. What's important is the DHA and maybe the T4.
Yeah. Is that what you're being told?
That's what I'm taking, and so I don't like it.
I don't blame you. So again, this is not about like, oh, if you have AFib or you're a woman and you're over a certain age, T3 is verboten. It's not that. It's we have to pay close attention. You have to be aware of the fact that in certain people, having a suppressed TSH and having a slightly elevated T3 might be an AFib instigator for some people. So it's just being aware of that. It's not that like T3 can never come back for you. We would just really go slow, like very, very slow, tiny doses. You just have to be careful. That's all. It doesn't mean that it's wrong or it's bad for you or any of those kind of things. So just being aware of what the patient needs.
Hey,
RBG?
the accounts, what do they have? HFA accounts and
Oh, HSA and FSA, health spending account and federal savings account, flexible savings account. So those are places where you can sock away money and then you can use it on healthcare related expenditures.
how does one find out about the cost of your services on
Why don't I just put the next slide? Go right there. So this is supposed to be hyperlinked. That's why it's in a funny color. But if you go to the website, you can explore the pricing's right on there. Initial consults, follow-ups. We actually do a membership plan where you pay a monthly fee so you can spread it out. You can see the physician as much as you want during that time, certain amounts of time during that time. We have a nutritionist, we have a health coach. So we have a really big team. We actually also have a pharmacist. My partner is a pharmacist, so he helps a lot with supplements and advising when we're not doing compounding. That's Dan's world. But so yeah, it's all in the website. Take a look at there.
Thank you. So you're actually local, but you're part of this group?
Yeah, this is the company I founded. So it's here in Milwaukee. It's a Milwaukee-based company, but it is a virtual medical group.
Really cool.
Yeah, we just
So maybe I'm in the dark ages, but I never heard of specifically functional medicine. What does
Oh.
that actually mean?
yeah. That probably would have been a really good thing to say at the beginning of the talk.
Yeah, because I'm hearing that term a lot.
Oh.
I think a lot of people know what
That's-
functional medicine is.
That shame on me for not defining that out ahead. All right, so functional medicine. Well, maybe we'll talk about it like holistic medicine. You probably heard that term.
Oh,
A
yeah.
little bit squishy term as well, but I think about that as kind of the umbrella over lots of different disciplines that would define themselves as being a little bit different from the traditional medical world. It used to be alternative medicine, and that's still around. And then it was complementary and alternative medicine, or CAM. So it's changed names a lot. But it's basically physicians and other practitioners, non-physicians, who want to adopt practices that are outside of traditional medical training. So I went to medical school, I learned all this stuff, and then I came out and I said, I didn't learn anything about nutrition, I didn't learn anything about stress, I didn't know any of this. So I went back and got more training to do that. So functional medicine, though, is the idea that we need to look for a root cause of a problem and figure that out if we can. We can't always, but if we can, then solve that problem. Don't just take a person with symptoms and put prescription Band-Aids on them and call it a day, which is kind of what traditional medicine has come to, right? You just you're tired, you get something to pick you up. You can't sleep, you get something to put you to sleep. You know, it just goes on and on and on. And again, medications aren't bad. I'm not being anti-medication. I'm just saying, if we can figure out why and solve that problem, like if it's an iodine deficiency, solve that, you know? So it's
like I'm one of these people that always has the mystery illnesses. I'll wait to go and finally go to the doctor, and they can't find anything wrong.
yeah.
And so I can